Hello, my name is Homei Wong. Thank you for including our paper in this session. This is a joint work with Mikhail Fioretti. We'll be looking at a performance pay reform in the Medicare Advantage market. So performance pay has been increasingly adopted in the healthcare sector as an alternative payment model that could potentially address some of the long-standing problems in healthcare, such as the high level of healthcare spending, but by contrast, very low values of these spending on actually improving patient health outcomes. And performance pay could be well suited to address this low value issue by basically directing spending towards services and providers who are known to improve patient outcomes. So the idea is that we can use this payment incentive to um, generate better outcomes and better improvements in health outcomes and do so potentially at lower costs. The challenge with performance pay is that it typically, in practice, is hard to align incentive between the principal and the agent. And in its application in the health insurance market, it will also be challenging to measure or construct an objective and biased measure of performance, which typically involves measuring patient health outcomes. So in the example, in this paper, we're going to illustrate with an example where the patient outcome turns out to be endogenous to the selection responses of insurers. So this paper will be examining a performance pay reform in health insurance, where the quality rating or the performance metric depends on the enrollee characteristics, including health or risks of these enrollees. And it just turns out that the quality rating is biased against riskier enrollees. And we find that the immediate response to the biased rating is to select healthier individuals, and the selection resulted in a significant decrease in the contract's risk score or the insurance company's risk score. But if we account for this risk composition change, there's very little effect of this policy on actual improvements in enrollee health. And there's negative consequences on the enrollees in general in that because the insurance companies going after healthier individuals, they're offering less generous coverage to the riskier individuals. So, it's going to harm the risk protection and the service availability, in particular, hurting the interests of the riskier population in Medicare. So the policy background is the Medicare Advantage program in the US. This is a private version of the public Medicare program, where private insurers is going to offer the Medicare insurance to the elderly population while receiving subsidies or payments from the government. And the quality initiative of ACA introduced performance pay in Medicare. In Medicare Advantage, it's going to exploit a pre-existing star rating system that has been giving out ratings to these contracts since 2009. And the rating basically ranks those contracts using a 2 to 5 star system. And in 2012, the payments would then be adjusted to the star rating of contracts. So the basic payment model goes like this. The insurance company is going to submit an asking price, which is their bid, to the government. And this bid summarizes their expected cost of covering an average enrollee. The government or the CMS is then going to compare the asking price with the external benchmark B, typically set at the county level. In most cases, the bid is going to fall below the benchmark. So in that case, the insurance company is going to first receive its asking price. In addition to that, it's going to receive a rebate, which is a fraction between the gap between the bid and the benchmark. And this rebate has to be passed on to enrollees as additional benefits or deductions on premium. And in the rare case where the bid goes above the benchmark, then the government pays no more than the benchmark, and the excess portion of the bid above the benchmark goes to enrollees additional premiums. So the payment incentive is for the insurance company to lower their cost, lower their asking price, at the same time generate more benefits to enrollees for them to stay competitive in the private market. And the bonus payment basically start linking the payment reform, start linking some of the payment parameters with the star rating. In particular, it adjusts to the benchmark and the rebate percentage point with the star rating. It is implemented in the ACA, passed signed into law in April 2010, and the biggest increase in the payment comes from a 5% increase in the benchmark that is restricted to contracts rated 4 stars and above. But then in order to benefit from this bonus pay, insurance company has incentive to start responding to it in a contract design immediately after the reform became law, that is in enrollment year 2011. early response to this policy is critical in the market because the quality rating is actually dependent on the health outcomes of previous enrollees. So in order for me to start benefiting from this policy in 2012, it's actually advisable that you start selecting healthier individuals as early as possible. And here we're going to look at these empirical patterns in terms of the risk score distribution for contracts with different baseline star ratings before the ACA in 2009 and 10. We find that for contracts rated no more than 3.5 stars in those baseline years, there's not much of a difference in the risk score distribution before and after. But then for those contracts with at least 1 4-star rating or above in those baseline years, there's a significant shift of the risk score to the lower half of the distribution. The density of those risk score at the lower percentiles increase, where the density in the middle chunk decreased. And we then make sure that this shift in the risk score occurred exactly in 2011. That is the first year that insurance company will be incentivized to respond to this reform. In the low-rated contracts consistent with no effect on the risk score distribution, there's also no effect in the density curves over years. We see overlapping density across our sample period. But then for the high-rated contracts, the shift to the lower percentiles of the risk score occurred exactly in 2011. That is the first year the insurance company will be incentivized to respond to the policy. And here we examine heterogeneous effects across different risk score distribution and quantiles. We basically estimate a quantile different diff that estimates the differential response across risk score quantiles in high versus low rated contracts before and after the policy. And we find that most of the risk reduction is concentrated among lower risk high rated contracts between the 20th to 40th percentile. So in other words, it's saying that it is the healthier contracts who are already enrolling healthier individuals before the policy that decrease the risk score even more, that enrolled even healthier individuals after the policy. But in contrast to the significant and heterogeneous impacts across the distribution of high-rated contracts, we do not see much of an effect on the average price in those contracts. So the context is that these contracts can offer multiple, or can cover multiple locations, and they can offer different premiums and benefit design across locations. But for now, we're going to ignore those within contract cross-location differences. We're just going to ask, what is the effect on the average premium in those contracts facing an average enrollee in those contracts? And the result is that there is no effect of this policy on those average prices. In particular, this policy has no effect on the average premium and the direct deductible in high versus low rated contracts. And it also has no effect on the average generosity facing an enrollee in a high rated contract. You're going to measure generosity using a rebate, which is basically the additional benefits the insurance company brings to its enrollees or the premium deduction. And it turns out, if we look at column 4, it turns out that after the policy, the enrollee share of the pie or the dollar amount of the rebate is basically 0. There's no increase or decrease in terms of the enrollee size of the pie. But then the policy did mechanically increase the benchmark awarded to the high-rated contracts. In response to this significant increase in the benchmark, high-rated contracts basically increased the bid even more, resulting in a smaller difference between the benchmark and the bid. But apply this, star adjustments on the rebate percentage point, the dollar amount of the rebate is actually held constant in column 4. So in other words, it says that the bonus payment in the short run is fully claimed by the high-rated contracts, with enrollees basically gaining very little from it. And this is a different trend that shows the bidding process. So in Panaway, this is a mechanic increase for those high-rated contracts, applying the star rating bonus. And in response to this bonus pay, insurance companies significantly increased the bid. And then the difference between the benchmark and the bid and the rebate basically was just constant over this period. So to explain the selection behavior, we need to explain 3 basic facts: that there is no effect on the average premium in those high-rated contracts, but then somehow they manage to significantly reduce the average risk of the average enrollee in those contracts. And in particular, we find even larger decreases in the risk in those contracts already enrolling healthier individuals. So we come up with a simple model that incorporates a few institutional features of this market that could potentially explain these selection results. First feature is that these contracts can cover multiple locations. And secondly, the rating is actually pooling enrollees across those locations. And thirdly, contracts the full freedom in basically changing premium benefit design across those locations. So given this institution features, the obvious thing the insurance company can do is to shift premiums from low to high risk counties. So basically differentially attract healthier individuals by offering cheaper products in healthier locations, but avoid riskier individuals in riskier locations. And because selection for the insurance company is just moving dollars around, you can easily keep the average price in the contract fixed, but then somehow they can change. But then by adjusting the enrollment share across different locations, different risks, they can improve the risk composition by lowering the average risk in the contract. So in the simple model, we're going to consider a contract setting premiums in two counties. And S going to give in county L what is the share of population in the county enrolled in the contract. The remainder share of the population would then be the default population who stay enrolled in the traditional fee-for-service Medicare. And we're going to use the big gamma fee-for-service to to denote the risk score of the fee-for-service enrollee in that county. And this parameter is important to the insurance company because the insurance company will be exposed to healthier potential enrollees in a county with lower fee-for-service risk score. So if you enter this county, or if you lower prices in this county, potentially you'll be joining in new customers that join from an average and a healthier pool of individuals on average. And we also allow the star rating to depend on the risk score at the contract level. In particular, a biased star rating would then biased star rating against the riskier enrollees would say that increasing the risk score of a contract tends to lower the star rating of that contract. And this generates the selection incentive for the insurance company to charge different premiums across counties to potentially manipulate the risk score and hence manipulate the star rating and the payments. So the obvious pricing strategy in this context could be given in this formula. And the nice thing is that if we do not have the biased rating or the biases in the rating, then you just go back to the standard pricing formula. The price is a markup above the cost. But if we have a biased rating, then we have this additional term, delta PL, which we call the pricing response to the bias rating. And in particular, this pricing response will be proportional to this partial effect, which says that to what extent can I change the contract level risk score by changing prices in one particular location. So the idea is that the insurance company will be changing premium more in those locations where changing the prices in that location will have a bigger impact on the contract level risk. And it turns out this partial effect is heavily related to the fee-for-service population in that location. And to make that relationship explicit, we can compare the premium responses across locations. So the differential premium responses between two locations turns out to be proportional to the differences in the fee-for-service risk score between these two locations. That is to say, relatively speaking, I'll be changing premium or increasing premium particularly more in those locations with particularly high fee-for-service risk scores. So the result of this pricing strategy is to differentially increase enrollment in the healthier locations and decrease enrollment in the riskier locations. And the result of the pricing of the selection is always in the direction of reducing the contract level risk score. So this pricing formula basically gives us a hint as to what kind of empirical strategy to employ to detect these pricing responses in the data. In particular, we can think about within contract diff to examine these premium differences within contracts across different counties, different fee-for-service risk score. In the reform context, we basically will be looking at whether these premium differences widened or became more significant across county risk scores, particularly in the high-rated contracts after the policy. So here is the different raw trends in terms of the price level inside high-rated contracts and inside low-rated contracts across the very high risk and very low risk counties in those contracts. And we find that there's an obvious pulling apart and significant deviation in those price trends in the high rated contracts, but not much of an effect in the low rated contracts. In particular, high rated contracts basically significantly increase the premium levels in its riskiest locations. Consistent with the average premium change, we also check the share of contracts offering zero party premiums. And we find that the offering of zero premium plans also deviated only in the high rated contracts, but not in the low rated contracts. In particular, high rated contracts are significantly less likely to have zero premium plans in its very high risk counties. So here are the regression tables. And in the first column, we look particularly inside the low rated contracts. And we did not find any meaningful relationship between the premium in a county and the fee-for-service risk in that county. In the column 2, if we look at the high-rate country, we find a significant positive relationship. In other words, premium set in the county is significantly predicted by increases in the fee-for-service risk score of that county. And in column 3, we look at the different triple difference effect, and that is basically driven by the significant premium differences within the high-rated contracts. And in column 4 to 6, we restrict our allocation to the risk tails within each contract and basically find the same effect. So basically, the average effect in the first 3 columns is not sensitive to a small set of counties, or you can call outlier counties. That's basically in the risk tails. So then we're going to use the premium differences to quantify the selection in those quality rating. By that, we mean we try to risk adjust the star rating by directly controlling for risk scores in a regression. But then the OS regression will be biased precisely because the risk score is selected. So you can overcome that issue by instrumenting risk score with premium differences within counties, within contracts across county risk scores. And the assumption for the IV strategy to work, first of all, is that the contracts varying premium more also should see greater reduction in the risk score, that is monotonicity. And secondly, the premium differences should not be related to non-risk factors in the star rating. In other words, the premium differences are really going after enrollee health and risks, and they're not going after any other characteristics that might also bias the star rating. So in order to show support for this claim or the plausibility of this claim, we show that premium differences, we do not find any meaningful premium differences across other local demographics. In other words, the premium differences are not going after different race groups or different education groups or different income groups. And also the premium differences are not going after those cross allocation differences in the provider cost and quality. So it's not driven by supply side of the healthcare market. And also the premium differences are not driven by the market competition within the Medicare Advantage market. In other words, the premium differences is not generated as a corollary of this market competitiveness across these different locations. And finally, if we adjust the fee-for-service risk score in the county with the coding intensity in the county so that we arrive at the pure measure of prevalence of these health conditions in a county, we actually find bigger and more significant premium differences across the health-adjusted county risk score. That is consistent with our story that the premium difference is really going after the enrollee risk misks, the health conditions of potential enrollees across counties. So we're then going to apply this IV strategy to study rating, to study potential biases in the star rating across different categories of quality measures. In particular, going to partition the star rating into 3 sets of measures. The biggest portion is the health outcome, which basically takes up half of the star rating. The remainder half is going to be split between access and process. We expect larger selection in the health outcome rating, not just because of the sheer size. If it can, improve ratings in the health outcome category, improve half of the final rating linked to payments. And it's also because the health outcome ratings are basically heavily reliant on the enrollee chronic conditions. In particular, a typical health outcome measure will calculate the share of enrollees or patients who are able to improve blood pressure, cholesterol, and blood sugar below a particular threshold. And then while computing these metrics, they do not adjust these thresholds with health conditions of enrollees. Although health conditions are heavily coded in the risk score for payment purposes, these rich information about enrollee health conditions and severity of these conditions are not applied in the computation of health outcome measures. This will create a problem because if you think about patients with more severe conditions who are more removed from these thresholds are less likely to improve their conditions beneath the thresholds, but these thresholds will not respond to the severity itself. So basically it says that without adjusting for patient severity by enforcing a uniform threshold or cut point across all conditions and patients, then it basically makes riskier patients with more severe conditions less profitable to insurance company because they're less likely to improve, and the insurance company in response will have incentive to avoid these patients. And when examine if that's indeed the case, or if there is indeed a significant concern in terms of the risk biases in the outcome ratings, and we do find that in the IV section of the table, and that risk score has significant impact on the outcome ratings in those contracts. In particular, reducing risk score by about 10 percentage points is going to increase the outcome rating by about 1.8 stars. if we apply this magnitude or this coefficient to the actual risk score reduction in high-rated contracts over this period, which is about 4 percentage point, we come up with a selection gain on the quality rating that can explain 80% of the actual improvement in the outcome rating for those contracts. So we're only adjusting for risk. We only have about 20% of the outcome rating improvement left that could be potentially attributed to actual improvements in the health outcomes of these enrollees. And then we basically adjust payments using the risk-adjusted rating for the 2014 star rating. And we find that selection incentive, or there's a selection bias basically exists across the range for different star beams. Even for the highest rated contracts, if we account for the risk composition change over time, there will be some deduction in terms of the star rating. Including for the 5 and 4.5 star contracts. But then the implication of that risk adjustment for payment obviously is an increasing function of how close you are to the cutoff. So basically, the closer you are to the cutoff, the risk adjustment will have greater damage, or will imply a greater share of these contracts will then be dropping below 4 stars and basically losing significant chunk of bonus payments upon risk adjustment. So to conclude, what we find is that biases in the quality rating can incentivize selection and distort payments. In the Medicare Advantage market, we find a failure to risk adjust the rating can lead to biases against riskier enrollees, and exploiting these biases, the insurance company would then, avoid these enrollees and differentially enroll healthier individuals and resulting in a significant decrease in the average risk score. But if we account for this risk composition change, there's very little potential improvement in the health outcomes as it's measured in outcome rating. So basically, the payment model wanted to reward contracts for improving the outcomes measured in the outcome rating, but then it turns out, if we adjust for the risks, there's very little measurable improvement in the health outcome. So it could be a concern that the payments in the short run at least seems to have inefficiently rewarded selection rather than health outcome improvements. And for the enrollees in general, this selection response has also weakened the risk protection for the riskier enrollees. In particular, the way the insurance contracts selected healthier individuals basically by shifting money and rebates around across location while holding the average total size of the pie to enrollee fixed. So basically, when healthier individuals gain additional benefits and generosity, it is the riskier individuals who's losing out in terms of receiving less generous coverage and benefits. So in other words, there will be adverse distribution or impact due to the selection incentive in response to this biased quality rating in the payment model.